report out of your discussion, where you're at. And again, if people had follow-up questions, comments about the discussion this morning about healthcare reform, please do send those to me and I will follow up. So why don't we get started? Allison and Kaya, do you mind reporting out first? Just a really brief idea of how it went.
Yeah, I will tell you, and Kaya, jump in. We're just having all the blunt conversations. We're just getting
Yeah.
at it about like
Success.
Yeah, I feel like we've been working with each other for like a year on this stuff, and we've just hit the point where we're just like, I know this idea might not be popular, but we need to talk about it.
That's great. Good, good, good. Great.
Yeah, I'll say what's nice for our group, we're trying to leverage work from other groups. So Kaya being vice chair of the health equity group, there's some work there that we've identified, in the list of trainings that need to be done. You don't need to
Cool.
create a new list.
Cool.
Um,
Yep.
So I'm just gonna cut and paste and put the references in, like what page of the report it came from and everything with the link, so that we can say from the health equity report.
no.
Great.
And the main summary for us is workforce is a limited resource. We need to treat it as such. So how do we have some hard conversations about what services can be provided where, and drawing the lines for that, but those lines are permeable. What did we call it with Kathy when we're talking to Dr. Levine? Permeable cells. Like
Yes.
Feel in and out of them.
Cell walls. Right, right. Yeah, that's great. Okay, anything else?
We've divided some sections and given some work with people's hats. I will say it's been nice to have, we do have Dan Toll in our group, and he's educated us on broadening what peer supports mean. I think we all had different ideas, but having him be able to be the one to put the words down instead of us interpreting, I think is going to be helpful.
That's great. Okay. Thank you. Laurel, you're next on my screen. Do you mind?
Nope, I don't. Unfortunately, Haley had to hop off for a different meeting, so it's me and our great pediatric subgroup members who are here today. We had done quite a bit of work in some of our recent subgroup meetings on our section of the report. So we decided to actually debrief the conversation that we heard this morning, and Dr. Soroyan John was in our group, which was great. So I'll share some of those notes with you, Kathy.
Great. Thank you.
And I would say the discussion kind of aligned some with what we have put forward. So in our subgroup and in the report, what we are highlighting is some of the work we did around clarifying some key guiding principles for pediatric healthcare when we're talking about integration. So what's kind of the unique aspects for children, youth, and families that need to be considered when we're talking about integrated care. So we have quite a few of those identified. We have a draft logic model around what integrated care in the children's world could look like, starting first with primary care. I thought was maybe we would do something similar for other settings, but that was our first one. And then we talked about the importance of, and maybe this is overlapping with another group, but it just came up as we were talking about it. How do you measure the integration itself? Not just the outcomes and impacts with patients, but and how through one of our recent federal grant projects, we were able to work with our evaluator out of VCHIP, who took a tool around measuring, it's like a self-assessment tool for providers to get a sense of like, where are you in integration work? And it was tailored for the pediatric world. Our evaluator helped tailor it. So that was something that we make note of. And then we just put forward some recommendations around what we think need to be the areas of focus to get started. I think there's plenty of work cut out for us. Some of our conversation today about this morning's discussion was around, there's still that driving need for a diagnosis and the pros and cons of that. And we talked about that in relation to certain populations, especially early childhood. And, we're like I said, the pros and cons. I won't rehash the conversation. And then how to really think about wellness activities. And if we're talking about a workforce, and Allison's comment this morning about kind of sharing roles potentially, you know, how could we lift up examples where that's happened well, and have those be understood and known by others? Because I think pockets of us know some good examples, but how do we spread that more broadly? So that was just couple nuggets from our conversation this morning.
Great.
Thanks.
Thank you. Steve, you're next on my screen.
Awesome. Thank you. Yeah, we had a very robust discussion, and I think it highlights the word I kept using was multidimensionality of, you know, thinking about funding and the alignment of funding and performance measures, and really what are we measuring? And like, to use the example that you just used, you know, are we measuring integration and the level of integration? Are we measuring the processes? Are we measuring the outcomes related to integration? But then, you know, there was a few different folks that really highlighted the limitations related to accessing data, and then data, the accompanying or associated data sources, specifically electronic health records, electronic medical records, having those systems talk to each other, or the barriers that there are that exist for those systems to talk to each other, especially as it relates back to care coordination. So if, you know, somebody is being transferred to a different system of care, let's say, for example, at Dartmouth Hitchcock, you know, how is that care coordination, and how are those patient records, you know, interfacing for folks? So really, again, thinking about those types of things. It was also discussed, which I think, again, is an opportunity for us as a work group, is having people from the community, peer community particularly, sitting at the table for these discussions, because if we're thinking about outcome measures, you know, how is that impacting patient or client care, and, you know, the impact of that care on those individuals, their families, their natural support. But really, again, thinking about, you know, is sitting at the table and ensuring that there's a level of, you know, when thinking about these being as in yeah, we talked a little bit about kind of the shared interest measures, specifically HEDIS measures. And I shared about for the Department of Mental Health and our new payment model that we've adopted, follow-up after hospitalization, and how there's other organizations like OneCare, for example, that's also tracking that. So I think, again, it's an opportunity for us to look at those measures that are being collected across the state that have, you know, physical and mental health implications. But then again, you know, thinking about it from a process improvement standpoint, you know, any metric has a process associated with it. So how do we ensure that there's some level of studying happening around those processes, you know, with the ultimate goal of trying to ultimately improve outcomes as a whole.
Okay.
So yeah, and Kaya raised her hand. I don't know if Kaya, if I
Yeah.
said something that sparked. So.
Actually, everyone said something that sparked.
Right.
One of the things I think we need to think about when we're looking at these things is the structural racism piece, because we're still talking about processes, data, structures, and thinking outside the box sometimes. Like, if we're going to measure outcomes, how are we going to measure outcomes for BIPOC folk, or maybe someone from who's a refugee? That we might be able to measure traditional outcomes that we are used to measuring, but how do we account for those other pieces, and how do we integrate practices that are culturally sensitive, such as Chinese medicine, maybe for someone, or some of those things. That's a conversation I think we all should be having in our groups, is how are we really thinking about this? Or, you know, are we being very white centered, or are we really trying to integrate some new stuff in based on, you know, health equity?
Good. Thank you,
That's all.
Kaya. It's
Could not
helpful.
agree more, Kaya. And again, Kaya and I have had this discussion, but around, what qualifies or constitutes data and
Yeah.
being inclusive of both quantitative and qualitative data. And especially
Yeah.
given that some groups have oral history, some groups have written history.
Yeah.
And are we being as inclusive as possible as a state and ensuring that all data, has an equal spot at the table? So thanks.
Well, and I just want to thank you, Kaya, because to say, because you mentioned before you started to speak that several people said things that made you want to speak, and it's something we've got to keep bringing up and talking about, because it's not how we've been doing business. So
Yeah.
it doesn't mean any kind of bad intent on anyone's part. It's just that it's not how we've been doing business, traditionally. So I think it's well worth just keep saying it.
I'll be the squeaky wheel. I always am. It feels like the meeting.
Well, and I'm just encouraging others. You think, say, hey, where's equity in here? Where are we? Please, keep bringing it up. So thank you.
And I'm still a
Um,
squeaky wheel too over here. I'm
That's
just-
good. Sam, and you were working, I think, with Cheryl.
Yeah, I was with Cheryl today. Thank you, Cheryl, for taking notes. Julie's on vacation, so I'm just going to give you a few high level points that we had today. So we did talk about a little bit about measures. We touched on it of how do you measure a person's life. And so that was a good discussion we had around that. And one point of clarity we had is a comment was made early on about we won't see the return on the investments for generations. And actually, that's actually not true. Return on investments are usually seen within a few years. And so
Sam, could I just interrupt you for a second? I'm
Yeah.
sorry. I just I didn't say your primary care. Okay, I just wanted to make sure it's primary care. So I'm
Yep.
sorry. Go
That's
ahead.
okay. That's totally fine. So some high level points that we discussed today, we don't want to create a separation of systems between mental health and physical health. And there was a discussion around CCBHCs, and even though the intent is not to separate, is it with CCBHCs, could that happen even more? So we talked about specialty care, just like a cardiologist. You go to see a cardiologist in a building, mental health, you go to a CCBHC for a specialty service. So we touched on that. We also discussed the need for trauma-informed coaches within primary care, as well as making sure that it's part-time work. A lot of people look for part-time work and not full-time, and so how can we influence that? Services should be available wherever the individual is most comfortable going. We need a place, like I said, for specialty care, but then a place for someone to go back to once that specialty care is no longer needed at that level. So they potentially could be connected to a peer within a primary care office, but go to a CCBHC for the specialty care and then return to the primary care once that service is no longer needed. But also, how do we as a group continue to build bridges and or break down barriers to having the care